So we'll come to the last presentation by Dr. MARIAN, who's head of orbit and oculoplasty at Giridhar Eye Institute. She'll be talking to us about complex periocular reconstruction.
Good morning. Thank you, Dr. Soumya, for the nice IC. Complex, I think this is a complex periocular reconstruction. I'll just show some cases. I mean, basic principles we have all learned from Dr. Soumya regarding the flaps, grafts, etc. So first I'll start with the masquerade procedure. So this is a procedure where it is used in when the upper lid and lower lid is deficient. Like most of the time we come across either upper lid or lower lid. But if both the lids are deficient, what can we do? So this is a kind of total tarsography by suturing the mobilized conjunctiva from both fornices and covering the anterior surface with a split graft. But here some problems are, it's usually done in extensive burns, then air bufferon, etc. Thing is the lid is unstable and can get lag of thalmos. So I will just show the surgical steps. So first the water lid available is split into anterior and posterior lamella. Then the posterior lamella is sutured together. Sometimes you can only conjunctiva, so you can close the conjunctiva together. If there are some residual lashes are there, you can actually excise the lash bearing area. So then create a wide defect like this and cover this with a full thickness skin graft. Initially the procedure when Converse was introduced, he used split thickness skin graft, but it has lot of contraction, and nowadays people are using full thickness skin graft. The skin graft can be taken from the sides which described by Dr. Soumya. And bolster dressing is done for 1 week. So after 2 months, you can divide the central part of the flap, keeping the both the canthai intact. And most of the time, we are doing when the cornea is compromised and the regular tarsography will not help. So further flap division can be done at 3 months, retaining the canthus depending on the situation. So this is one patient. He is 46 years, hot water burns, had undergone multiple reconstructions from elsewhere, and in fact he was referred to us for evisceration. So then, when we looked into it, we thought we will do masquerade. So I operated along with Dr. Vinay, our corneal surgeon. So he underwent masquerade procedure with the penetrating keratoplasty, and after flap division, he was doing well, and there is no lag of thalmos. Only problem, the blink will be little deficient, but that is why you are keeping this eye lens on both sides. So this is again another young girl. She's had total bufferon. It's a kind of coloboma involving both upper lid and lower lid. This is a congenital defect. It's a syndromic baby. Somebody has already attempted a tarsography at birth, but somehow it didn't work. So one eye, when the child presented to us, left eye already perforated almost into pre-thesical stage. So right eye, we thought we will save the vision. So again we did a masquerade procedure and kept it like this. And after 2 months we did a partial flap division, keeping the central area. And at this point she was awaiting keratoplasty, and recently she underwent anterior lamellar keratoplasty. And now she is actually able to read at least to 3 meters, and she is awaiting school now. So now coming to the upper lid reconstruction. Upper lid reconstruction when the defect is more than 50%. So this is the defect. You can see almost more than half of almost full lid is not there. Only the good advantage is the canthus is intact. So you need to reconstruct only the lid. So we go for Cutler Bird procedure. So in Cutler Bird, what we do is incision is 2 to 3 millimeter down the lower lid margin, and it's a composite flap taken and attached to the individual layers, conjunctiva to conjunctiva, muscle to muscle. And after 4 weeks, the flap is divided and the lid margins are formed, and this is his postoperative picture. And there is no lag of thalmos, even though minimal retraction is there. So coming to another case again. So this is a tumor involving the upper lid as well as the canthus. So here you have to reconstruct the canthus also. This is the defect after excision. So here what we have done is, one option is you can go ahead with the Cutler Bird, and you can get away with Cutler Bird. But actually Cutler Bird, the thing, I feel it is not a physiological because it doesn't have any much stability. So in this case what I did is, I did reverse modified Hughes. We know Hughes is the procedure done for lower eyelid reconstruction. So we have reversed the Hughes. So what we do is incision is 2 millimeter beneath the lid margin and lift conjunctiva and tarsus. Tarsoconjunctival is again tarsoconjunctival flap. Suture it to the residual conjunctiva in the upper lid, and then residual, there's a defect, so that what can, here the tarsus is only 2 millimeters, you need to get little more stability. So I have taken a free tarsal graft from the other eye to increase the length of the lid, because the upper lid, the length of the tarsus is nearly 8 to 10 millimeters. So at least you need some 6 millimeters at least. I mean minimum 4, but 6 millimeter gives you very good result. So now we have got a flap and then a graft. So now what I did is I mobilized the orbicularis from the orbital part and kept it over the top. So this is the mobilized orbicularis over the graft, that is free tarsal graft taken from the other eye, and then I covered the anterior lamella with a full thickness skin graft. So this also he underwent flap division at 4 weeks and he did well. So this is another method of reconstructing the upper eyelid. This is also a similar case again. So nowadays I prefer reverse Hughes. So now the defect is this is another patient where the defect is involving the both lateral part of the upper eyelid, canthus, and lateral part of the lower eyelid. So this is the existing defect. So for this posterior lamella, I have taken a periosteal flap. She had a very loose lid, so periosteal flap from the lateral orbital rim. And for the anterior lamella, I have taken a Fricke, and what I have done is this flap I have divided into two. I mean, basically one part goes to the lower lid and one part to the upper lid, and the rest of the defect is covered by advancement flap, and there is a small skin graft also. So she also did well with even though aesthetic is not very great, but she is doing well. Because in oncology, we look more into the principles like 4 millimeter margin clearance rather than the aesthetics. So lower lid cuke, I'll just take 1 minute. So this is an extensive lower eyelid defect, again sebaceous gland carcinoma. So it's naturally Hughes, this is a small video. So this is the Hughes, the other one is the reverse Hughes. So again 4 millimeter tumor is removed. So this is the defect. Here also the canthus is involved. So for the canthus I have taken a periosteal flap. Then for the Hughes flap, tarsoconjunctival flap is taken, and it is attached to the lower conjunctiva. Then the upper lid, I form the canthus. So these are the suturing part. So canthus, periosteal flap, here direct closure, and then posterior lamella by Hughes. Then for the anterior lamella, I have taken a small Trippier flap. So the skin is, she had very much loose skin. And this is rotated down. The good thing is it has got a bucket handle effect. So it will not go for a lower lid retraction. And sutured to the residual anterior lamella. So this was her postoperative picture, and she did well. The challenges are, there are some real challenges. That is, he is a one-eyed patient with an extensive BCC with black cataract. So here I don't want to do a bridge flap because he will be blind for another 2 to 3 weeks. So what I did is, since the other eye I have taken a free tarsal graft and have taken a skin graft. He had an element of graft necrosis, but anyway he did well, and he underwent cataract surgery also. So this is another defect again involving middle canthus, extensive the whole lower lid. So again lower lid, posterior lamella with the Hughes, and anterior lamella have taken an nasolabial flap, and the lateral part with a small skin graft, and again BCC, and she also did well. Eyelid avulsion, composite graft if you get the residual eyelid. And for the eyebrow defects, you can actually get away with the myocutaneous flaps, advance from both sides, switch it together, and they will do well. So to conclude, it's a very complex undertaking. Always respect the anatomy. We need to reconstruct both the lamella, and if you are not able to reconstruct, at least do a temporary tarsography and get a help from somebody to reconstruct it. Very gratifying. Thank you.